Very good afternoon to all. Happy to see you all. So warm welcome to the foundation course in palliative nursing. Today we are going to learn about palliative care. As senior said, Dr. Sreedevi Warrier is our faculty. She is a palliative care physician and also working as a department head in education and skill building, Trivandrum Institute of Palliative Science. And she did her certificate course in pain and palliative medicine from Pallium India and fellowship in palliative medicine from Institute of Palliative Medicine. And also she did her MSc palliative care from Cardiff University. She has around 15 years of experience in palliative care. Madam, welcome and over to you.
Thank you all the nurses for joining us for this training program. I really want you to be as interactive as possible, not just today, but throughout the sessions. We'll be seeing each other, or at least we'll be seeing our team for another 17 more sessions. So it is very important to have interaction. And if you find any difficulty in following what we are sharing, please raise your hand. We are happy to explain it how many times you want. I'm happy to go over it again and again. I hope everyone can follow English in this group. And maybe as a first session, it will be nice to see your faces for a minute. I know some of you will have problems in your network, but it will be nice to see everyone at least while we are starting. So I request everyone to switch on their cameras. And it will be nice if there is no network issue, if we can keep it on so that I feel good that I'm talking to human beings and people are listening and reacting. Otherwise, it is pretty boring to look at the screen and teaching. So it's always good to see some face. Thank you so much. And whenever you find any network issue, kindly let us know. And whenever you think that you are unable to follow, just let me know. Someone has raised their hand. Is it by mistake or do you have anything to tell? I think it's Randive. I think by mistake maybe. Yeah. So I'll start by asking, what do you have? Has everyone heard about palliative care? Exposed to palliative care, heard about it, but not sure what it is all about. What do you think? Has everyone heard about palliative care in this group? You can either raise your hand or you can type it in the chat, yes or no.
Yes, ma'am. Yes, ma'am.
We've heard about what palliative care is. Anyone else?
Yes, ma'am. We have heard.
Yes. Anyone already working in palliative care, already practicing palliative care?
Yeah, there are 4 of us from Cipla Palliative Care, Pune.
Great. So you're already working in palliative care, right? For how long, Sister Maria?
I'm working for 2 years. Two of us are working for 2 years.
Okay.
And maybe another one for 5 years. Rahul is for 5 years. And Deepali was working first. Again, she left. She did higher studies, came back.
Okay.
She has joined us.
Great. So there are so many people who knows the basics, but it's a mixed group, I guess. So some people have heard, some people are already working, some people are yet to learn more about palliative care. So I'll touch upon the basics and we'll make it case-based and interactive as possible. Okay. So I'll just start sharing my presentation. Can everyone see the slide? I guess I think everyone can see the. So what do you understand from what I've written and from the picture? Anything that you can figure out? It's just a picture or is it conveying something to you?
Um,
Yes.
it's depicting, yeah, may I, ma'am?
Yes, please, please.
Yeah, it's depicting a human face, and the head is like full of thunders and rains, and also fire, ignition, and the dry, burnt trees, which is signifying, like, according to me, it is like a patient is going through a lot of suffering and pain and trauma in his mind, and also the pain is the patient is like tearing. Sorry, the face is like tearing, which depicts the suffering. The patient is having so much of pain and psychological issues. And so the words depict, please treat my suffering, not my disease. So it is like symptomatic treatment, like which patient is asking for in my suggestion.
Thank you, Sister Hema, for the wonderful description of the picture. Anyone else
you.
would like to add on to what Sister Hema just shared? Anything that you want to add that you have noticed? So this is one important learning. We will be able to read those suffering only when we try to look into it, try to spend some time on it. Otherwise, I mean, this picture or the patient, the face in the picture is pretty calm. It is not like someone is screaming or crying or agitated. So unless we spend time in understanding what they're going through, we can't see what is happening inside their head. It is always hidden. We may not be able to see that single drop of tear or the creases on the face unless we spend some time and understand what they might be going through. So, just touching upon why I put that picture. So, what happens? So, do you think a patients who are or people who have, for example, an acute illness, like someone had a bad respiratory infection, should they get palliative care? There is suffering there. It is not just the disease, they also have suffering. They have a bad lower respiratory tract infection or upper respiratory tract infection. A week, they will suffer like anything, right? We may not be able to go for work. We will have cough, wheeze, headache. So, do they need palliative care? So, what happens when there is an acute illness? So, many of us will have many acute illness, right? One day you will be having fever and other issues. We can go to hospital. We'll get some medications, or you'll ask your colleague doctor, ask for some medication, and then we come back home. Maybe we'll have to take leave for 3-4 days or a week. Probably you will have to sit at home, but we will be back to normal after a week, right? You can go back to work. You can go back to hospital, and you will be kind of you'll be having a little bit tiredness here and there if it is a viral infection. But within a week or two, normally we'll be back to our routine work. But is it the same for when there is a chronic illness? What happens when there is a chronic illness? They'll go to hospital for sure. And then what happens? Will they come back home and start going for work next day? No. So Priyanka has conveyed no, they can't go back to work in next day. Or will it take, yeah, routine gets disturbed for sure. And for how long? Mostly. For most patients, it is forever, right? They may not be able to go back to work forever, or maybe for months, maybe for years, probably. And yes, Jyotsna has mentioned about the work routine gets disturbed. It can lead to financial distress because after a few leaves, we have to go for loss of pay, right? Every one of us. We can take leave for a week, maybe two, but after that, you have to give your salary back to your hospital. So, what happens when there is someone who had a fall from a tree and became paraplegic? He'll be going to hospital, getting the spine fixation, the neurosurgery, whichever is needed, getting done. But then they come back to home. They are not going to go back and climb the coconut tree next day, right? That will be the only trade that he might be knowing. Climbing coconut tree is what he knows. He cannot go back to the same job. Instead, he is on wheelchair, he is on bed, he might need help for each and every single thing. Or we can take an example of a patient with advanced malignancy. I've just written an example of cancer lungs, but any advanced malignancy. They'll go to hospital, they come back home, but most of their routine, the world, complete world around them will be changed. Everything changed when we all had COVID, right? Every routine changed for weeks, for months. We were anxious. We did not know how to take care of our family. We did not know how to go for a job. What if I lose? Many people lost their job. Because we are all in healthcare, we had more job, but many people lost their job. So this is exactly what happens without COVID in a chronically ill patient. What happens when someone has a stroke? They'll go to hospital, they'll get all the immediate treatment that is needed. They come back with a little bit of disability, right? They will not be back to normal. They'll not be going to office, getting onto bus next day morning. The entire family and the patient's life gets rearranged. Everything changes. The whole story changes by then. Like in movies, we see after interval, everything starts changing. So after this kind of diagnosis, the whole story gets changed. So many a times they get the reply from the hospital that they did the neurosurgery, spine fixation. Still, the patient's concern will be what? I'm unable to move my limbs. He is not worried about what kind of implant that you fixed, what kind of injection that you gave. They are not worried about it. They'll be worried about, I cannot move my limbs. So generally what doctors will say, oh, we have done everything possible. Even in movies we see, no, we have done everything possible, but it is out of our hands. There is nothing more we can do. So in palliative care, from today onwards, I want you all to start thinking that there is always something that we can do. It can be a very small thing. It may not be, but it can be life-changing for many patients. At least talking to them about what is going to happen. So if we have an illness, don't we expect our doctors to explain what is happening? We will ask 100 questions, right? When it is going to be all right? When am I going to go back to work? How long should I take leave? Can these antibiotics work in a week? So all these questions we'll have. So at least if we answer the questions that patients have, that is something that can be very, very meaningful. So from today onwards, we have to start believing that there is always something that we will be able to do. So this is, I don't want you to read the statistics, but in 2017, there was a survey done by the Lancet Commission, and they found that at least 10 million people in India has serious health-related suffering, like any life-limiting illness-related suffering. So that is it is not very rare that we need to give palliative care, right? It is not so difficult to find patients who need palliative care. It is there everywhere around. If you start seeing in your own hospital from today onwards, you will see a lot of patients who will be undergoing suffering because of their illness. And what happens when you have an illness, long-term illness? What happens if you have a long-term illness, our own family, in terms of finances? Sometime back, Jyotsna mentioned about the financial crisis. You take our own example. We're all working in hospital. We all get salary on day 1 or 2 of the month, right? And we have to pay the rent, the loans, and children's education and our own stuff. What happens if there is an illness? 1 month you are supposed to take an MRI and to take some medications. It changes many things, right? Oh my God, where am I going to find money for MRI? That will cost, I mean, both sides. I'll have to spend at least 6,000, 8,000 rupees for an MRI. Now what will I do? That month we'll have to borrow money. What if you have to go through it every month? So what happens to patients when they are generally given prescriptions? We give them prescriptions. I can see, can you just open the chat? So there are few responses in the chat. Yes. Need to compromise with other important expenses. Sometimes we may not be able to pay the rent for that month because that month we may have to take an MRI, or we may have to spend something for our medications. And Sister Hema has mentioned everyone in the family will be affected. It is not just us, no, our kids will go through it. Okay, we will tell, okay, this month, no, I can't buy this because I have to spend money for medical expenses. So what happens to our patients? Even a single investigation that we write, a lot of investigations we write, right? Most of the times just to check whether the counts have come up, or just to check whether this is okay. I'm not talking about a patient who came with an acute illness. I'm talking about a patient with a prolonged illness. Even the moment when we start writing something, they'll have to pay money. So because of this practice, many of the patients or the families in India will be pushed below poverty. I'm not sure. You'll be seeing a lot of patients in hospitals for a chronic illness. When they come, they'll be well dressed, they'll have a lot of money, from a middle class family, but maybe after a prolonged ICU admission or something, they'll be completely bankrupt. There will not be anything remaining for them. So healthcare is one reason why people go below poverty line. And this is the formal definition of palliative care, which is it has come decades back, still not revised. But I have highlighted the areas which you need to focus on. Why we are doing palliative care? What is the aim of palliative care? The only aim is to improve quality of life. If someone is having prolonged symptoms like pain, someone is continuously vomiting since morning, we know that there is a bowel obstruction. We may not be able to do a surgical procedure because that might be out of scope, but we will be able to reduce the vomiting and other symptoms so that they can live with a better quality of life. What quality of life when they keep vomiting, or when they have a foul smelling wound? It is very difficult, no? Even when we sweat, if we smell bad, we will become very conscious. Oh my God, am I smelling so bad? So what if someone has a foul smelling wound? Even with a small pimple on our face or small pigmentation, we'll be so bothered, right? Every time we'll keep looking whether it has gone, whether everyone will notice. So what happens to patients who have an ugly wound on their face or anywhere in their body? Their quality of life is very well compromised. So I can see a comment from Sister Stella. Yes, psychological suffering to the patient. So whenever there is a chronic illness, whenever there are a lot of things to be done, it can affect the patient as well as the immediate family members. So that is exactly I have highlighted in the definition also. It is not just about patient. It is about their families. The whole family system get disrupted. And for whom? It is for patients with life-limiting illnesses. Can everyone say a few examples of life-limiting illnesses? We talked about cancer now. What are the other life-limiting illnesses that you can think of? A few I have mentioned in my slide, but anything else that you see or you think can come under life-limiting illness? Diabetic food, very, very good. Even I think uncontrolled diabetes itself can be a problem. CVA, yes. Spinal cord injury, very good. CKD, yes. Especially end-stage kidney disease. Any other life-limiting illness? And why do we say it is life-limiting? ALS, yes. So when I am seeing this response, I'm assuming that you have these kind of patients in your setting already? Or is it from your theory knowledge, or you are actually seeing these kind of patients? Yes. Sister Benisha has responded, yes.
We have seen these patients in our hospital.
Okay, okay. Congenital limb deficiency, yes. I think in that matter, any congenital anomaly for children with congenital anomalies, we can say in general with life-limiting illness. Why do you say that it is life-limiting? What is it limiting? How can it be a life-limiting illness? Any guess? It's not a big question. I just wanted to know, why do you think? Yeah. They may not be able to live a normal life. It is limiting their day-to-day activities or their normal life. So all these illnesses that you mentioned and many, many more comes under life-limiting illnesses. Thank you so much for the response. And very often, palliative care should be started early in the course of illness. What happens generally? People who are already working in palliative care will be very familiar that we get patients at a very late stage. We get when they become bedridden, or sometimes when they are about to die, when there is nothing, they can't even speak, they can't even breathe. At that time, people get referred to palliative care. So, but the WHO has recommended that it has to be started very early in the course of illness. Why do you think it should be applied early in the course of illness? Someone who just got diagnosed with cancer, I mean, he's or she is yet to undergo chemotherapy, radiotherapy, or surgery, many, many options. Why should we start palliative care early in the course of illness? And do you think it is needed? Yes. So everyone agrees that it is needed. Yes. So there is no argument that it is needed. But is it easy to talk about palliative care early in the course of illness? The moment you start talking about it, people think that they are dying. I mean, that is the experience that we have. At the moment you start talking a little bit about palliative care, then they think that, oh, maybe, yeah, Ashwati, thank you for the response. Yes, if we start early in the course of illness, it can improve their quality of life in a much better way. We should be able to have a rapport with the patient. No, we have to know who the patient was, what he or she wants, what are the issues that they are going through. The patient should be able to communicate. Not when they are dying, they should get palliative care. So yes, that is a very important point. The news of a life-limiting or life-threatening illness causes distress. So the moment you talk about a life-limiting illness, it changes patient's life. It causes a lot of distress, and that is the time when they need the maximum support. They need to understand, and they need to be taken through the course of illness with a lot of support. And they will have a good insight and support, and also have someone to ask and say things. That is also very important. They'll be very scared. They will not ask the doctor most of the things. They'll have 100 questions in their head. So it is important to have someone to whom they can ask questions and have a clarity. Okay, how is this going to be? What all I'm going to deal with in future? How my treatment is going to be? Will I have pain? Will I be breathless? So all these things need to be addressed as early as possible. Thank you all for the wonderful response. Little bit of history. I'm not going into details, just two things to remember. Who started palliative care movement? Dame Cicely Saunders, and started the first hospice in 1967. And Dame Cicely Saunders was a nurse who was working in England in the war, and she was helping soldiers to get pain relief. And she understood that whatever she was doing, the pain relief was inadequate. Her hands were tied. Like many other times, a nurse cannot take decisions. It is much better in England, much worse in our country. Although they'll have a lot of knowledge with their hand, they can't take most of the decisions. So Cicely Saunders decided to become a doctor and a social worker later. So she is a nurse, doctor, and a social worker. Everything. It's a multidisciplinary team herself in one person. She started the first hospice, which is a St. Christopher Hospice, which is situated in London in the year 1967. Only this much you need to know. Who is Cicely Saunders, and who started palliative care, and where it was started and when. So that's about the history of it. I'm not going into the detailed history. But what happened? It started in 1967. Still, in a country like ours, people like this are still going through a lot of suffering. and only 4%, less than 4% of people in need has access to pain relief. It is not just about palliative care, a basic pain relief. I don't know how many of your hospital has a good pain relief policy in place. People just cry, and we generally say pain is a part of the illness. Or does your hospital have a pain relief policy? Do we take care? Do we assess pain regularly, then give adequate analgesics? Then you ask patients how bad is your pain? Does that happen in your setting? And of course, in SIPLA, I can imagine, but in other setting, is this a routine? Yes, I can see yes from Vaijayanti that it is. Yeah, you have a pain relief policy in AIMS. So there are 3 responses which says yes. I'm glad to see that, because many a times when we talk about access to pain relief, even the proper analgesics is not available in many of the setting. It does happen, though not a policy in my country. Yeah, but I'm glad that it is happening. People talk about pain relief. Many a times it doesn't happen. They don't talk. And still, Kerala is supposed to be the champions in palliative care, but still we can hear patients telling that doctor told it's a part of your illness. Pain is a part of your illness. So not getting adequate pain relief. So again, I am very fond of sharing stories, because that's how we learn and that's how we interact with each other and learn from each other. So this is the story of Mr. A. He was diagnosed with cancer and he was on disease modifying treatment from a cancer center. So he's undergoing treatment from a cancer center. He has a wife and 3 children and an elderly mother at home to take care of. And looking at Mr. A, we have told many causes in the chat, what all patients will go through. But looking at Mr. A, what all can you think of? Like, what will be going through in his head right now? When this is how we found Mr. A at home, what is the first thing that comes to your mind when you see someone sitting like this? Yes. I'm glad that no one started with the physical issue first. Yes, he looks worried. He could be worried about his disease. So the first 2 responses are about the worry. I really appreciate that. I mean, generally, when you ask doctors, they say he's in severe pain. Yes, Sister Vaijayanti, he has so much of pain. Very good response. Anxious about family's future, worried about family. Sister Ashwati, another important point. Very important, we don't talk about it. He can't even eat through mouth. We think that, okay, there is an NG to what is a problem. He's anyway eating. So eating through mouth is a very important thing for all of us. Whether you are fed, whether you are not hungry, eating through mouth is something to do with the dignity. Yes, worried about his law. You can see how emaciated he is. You can see his bone very prominent, the clavicle, and he's very skin and bone. Yeah, possible that he might be worried about the health of himself as well as the family members. How are they going to cope? Because of he's thinking about his family. I'm glad that you are all thinking about him, thinking about the family. So I'll just when we explored more on Mr. A, this is usually the first thing that comes to everyone's mind. Will I be able to pay by medical bills? The moment you talk about treatment, they will ask you how much will it cost? Is it an expensive treatment? So what happens in government sectors then? It is given for free, right? Can it still be expensive? In government hospitals, if you are taking treatment and the patient is telling you that I cannot afford treatment, what will be your response? You're giving it for free. In AIMS, you give it for free, right, Jyotsna? Most of the treatment. No. But in government sectors, yes. It is not fully free in AIMS. Okay. Yeah. So what happens is that still there are a lot of expenses, as someone mentioned in the chat, because to come to the hospital, you need your wife who will be going for a job, maybe on a daily wages. They have to take leave from the job, and then they have to take a rickshaw or an ambulance, maybe. They charge exorbitantly high if you have a patient to be taken. The auto rickshaw has to wait till evening. And you might have seen outside AIMS in Delhi or in Tata Memorial Hospital in Mumbai, people live on streets. They just live there because they can't go back home and come back every day for radiation, and they don't get admitted for radiation. Right? They need not be admitted for radiation. So there is a lot of bills that they otherwise have to pay. Some of the investigations will be sent out. So just mostly worried about how am I going to manage my finances. And as you all have mentioned, how am I going to take care of my family? Now I cannot go for work anymore. In this situation, I cannot think of going back to work. So who is going to take care of my family? This is very common worry that patients will have when they go through a serious illness. And another, someone mentioned, I am unable to eat through mouth. That is a very important concern. We think that there is a tube, he is fed, but people want to eat through mouth. And I don't want to eat or talk because of severe pain. The tube is there, I am fed every time, but I don't want to eat or I don't want to talk to you people because it is very painful. I am unable to sleep. It can be due to pain. It can be due to all the reasons that you just now mentioned. And it is very interesting to see that Stella has mentioned about the sexuality issues. We just don't talk about this. It is a very stigmatic term. The moment you start talking about it, then we ourselves are very uncomfortable in exploring how does it affect your sexuality. So that we don't talk at all. So this lack of sleep can be due to various reasons, including uncontrolled pain. Is this a very common question? Most of the settings, right? Am I going to die now? I'm in severe pain. I'm losing a lot of weight. I can't get up on my own. I need help to do activities of daily living. Does that mean that I'm going to die? No. So these were the issues that Mr. A was going through. And Mr. A is a representation of many, many patients that we see on a regular basis. So we can put it under 4 domains. Physical domain, where he has lack of sleep, he has severe pain, he has difficulty in swallowing. All these can come under physical domain. And in the psychological, you all have mentioned, it is about worried about the family. Am I going to die? A lot of anxiety because he has lost weight. So that can have a very negative impact. He can become anxious or even depressed. What are the socio-economic? Will he be ever invited to a family function? Okay, suppose we gave good pain relief. Mr. A is pain-free and he can have good feeds through the tube. He's fine. But will he be invited to a social gathering? Okay, there is a family get-together happening or a marriage in their family. Will Mr. A ever be invited to that? Most often, no. Even if someone invites him, he may not be able to go because of all the tube. Many patients, the tube itself is a problem with their negative body image. So a lot of social reasons, social isolation or self-isolation from the society. And then there is a lot of spiritual distress where generally they ask, am I being punished for whatever I've done in my life? I have, or sometimes they think that I have not had any alcohol. I was never a smoker, but still I have to go through all this. So am I being punished for all this? So all this spiritual distress. Or sometimes they ask themselves, why am I being alive like this? There is no point. I'm being a burden to my wife. I am a burden to my children. So why am I being alive? Do you get such questions in your setting? Do they share these kind of questions with you?
Yes, ma'am.
Yes.
They do say that because of me, even my family is suffering.
Yeah, very common, right? Even with small illness, we feel that, right? Whenever we have some fever or headache or something, we ask our kids to do that, this, or you have to ask someone to take care of. You feel that, oh my God, am I bothering them? They have to take care of me now. And most Sister Jolsna has said most of them ask why me. So it is not just from, I understand that it is not just written on the textbooks. Many of you have gone through this, have heard these questions, right? Asking us like why this happening and what is happening. Did I do something wrong in the past? Sometimes they blame God. Sometimes they blame, okay, the neighbor used to do something, so that's why I got this illness. So many spiritual distress that they go through when they have a life limiting illness. So it is not just about a physical distress, but illness related suffering is much above that, much beyond that. As we started in the beginning, we saw a picture, we tried to read what exactly is in that picture. It is very important to spend more time to understand what is that illness related suffering that they are going through. So whatever we see, so all of us have seen the Titanic movie, right? Where they just thought that it is the small ice, but it was a huge iceberg. They just saw the tip of the iceberg and how a tragic accident happened. So it is very important to understand what is there under the tip of the iceberg. We see he's worried, he might be anxious, he is having severe pain, but under that, there will be a lot of issues that they may not be able to tell you. Unless you ask more, what is worrying you the most? What is affecting you the most? They may not be able to tell you what exactly is the reason for suffering. Even if you give whatever analgesics that you have, they will still tell you, I am still having pain. The moment you start understanding what is the reason for pain, we'll be able to treat it better. So this is just, I understand most of you know the concept of palliative care. Palliative care is not just for someone who is dying or someone who doesn't have anything more to get, but palliative care should start early in the course of illness. So what happened? Let's take the example of Mr. A. If Mr. A was given palliative care referral much before, his pain would have been controlled. He would have eaten better because we'll be able to control the dysphagia, the odynophagia a little bit. Pain while swallowing can be controlled. Or we might have talked about, okay, what are the side effects of radiotherapy? During radiation, you may need a rise tube, but it is temporary. You will have a lot of mucositis. It will be painful, but we can treat it. So we could have prepared Mr. A. We could have prepared Mr. A's family if he was referred much earlier. And then during the progression of illness, when the disease is getting worse, our need will be more. There will be more pain, there will be more symptoms, more distress. So the palliative care will increase over a period of time. So the disease modifying, the curative treatment will come down, but the palliative care will increase. And do we stop when the patient dies? We told that in the definition, palliative care is for patient and the family. Even if the patient dies, we still have the family member there, right? Family member is there. We are taking care of the family also. And you saw Mr. A was worried very much about his family. Was thinking, what will happen to my family when I'm not there anymore? And that is a very common concern. We all think that, no, if I'm no more, who's going to take care of our kids? Who's going to take care of my family? If you get the assurance that, okay, there is a team who is going to ask whether my family is okay, that gives a lot of relief to the patient. So it is very important to continue palliative care even if the patient is no more. We help the family members to cope with the absence. You cannot replace Mr. A there, but we will help the family to cope with the absence of Mr. A. Are they coping really well? Is anyone has a suicide tendency? Are they getting enough support from the family? Is there a source of income? Is Mr. A's wife able to go for work? Are the children going to school properly? So all this will be addressed even after Mr. A is not there anymore. So this is just one slide telling the difference between the perception and the reality of palliative care. Everyone think that it is the end resort. When the plant is about to die, we help the plant to die. That's what everyone thinks. So you people help people to die in a peaceful way? No, that is not the fact. This slide should help you. If someone asks you, what is palliative care? Or is it end of life care? You can always show this picture. It is about giving a strong support in the root, right? The root of the plant should be supported really well by the community because the patient is living in the community. You need a lot of support in the community. And what we doctors and nurses will do, we give pain relief and symptom management. We will water the plant every day. We'll water the plant with adequate medications, counseling, and other support. And what happens to the family members? We are supporting the family member. We are restoring the dignity. So the plant is not literally dying, it is flowering. There are still family members who are alive. Only Mr. A is going through the life-limiting illness. And a lot of communication and caregiver support. And above all, preparing for death. So we are not telling that giving palliative care will make people immortal. No, that is not the aim. People are going to die with life-limiting illnesses, but we prepare them better. If we get to know them early, we can prepare them. So you can confidently say through this picture that it is not about the dying plant. It is about helping the dying plant to be stronger and to bloom in a better way. And the plant can die with dignity and with lot of support from the community. So I'm not going into one by one. It is very small thing. I try to include everything in one slide. You can read it when you get these slides. So it is the same thing that we have been discussing. It is not about hastening death or helping someone to die, but it is all about helping them to have a comfortable quality of life, dignified living and dying. I'm not reading one by one. It is just about the myth and the realities of palliative care. And palliative care will start. So initially, we may not have much role in such patients' life. Maybe just pain relief will be enough. But when they are moving to terminal illness, when they are moving to pre-active dying and then actively dying, the role of palliative care intensifies. Our care should increase when someone is dying. What happens in routine hospital setting when someone is dying? The care they'll reduce because anyway the patient is dying. You can take home. There is nothing more we can do. So the intensity of care can decrease. But when it comes to palliative care, our job increases when someone is dying, making sure that they are dying and living in a dignified way. And what is the disease burden? It is not, we are not just talking about cancer. We are now you mentioned in the chat about diabetes, diabetic food someone mentioned, and you already mentioned COPDs. We talked about cancer. I think we missed about cardiovascular diseases, end-stage cardiac illness. We didn't talk about it. But it is not just about cancer. It is about 75% of other non-communicable diseases also. So when we talk about, okay, who needs palliative care? Who all should get palliative care? Now, sometime back, we put it in the chat about the names of lot of illness, right? CKD, ALS, and then we talked about diabetes and congenital anomalies. those kind of illnesses we talked about. So you can see more than cancer, patients with cardiovascular disease needs palliative care. But how many of them we see in a regular setting? I don't see much cardiovascular disease. And you can see how many illness needs palliative care in the end. HIV, we don't have much referral for HIV, but HIV is much better compared to other infectious diseases, COPDs, Parkinson's, and tuberculosis, multi-drug resistant tuberculosis, rheumatoid arthritis, a lot of illness like end-stage liver disease. There are a lot of illness beyond cancer which needs palliative care. And this is about adults. Now let's talk about children. Someone mentioned about the congenital abnormalities. And do we talk about children when it comes to palliative care? Very rarely we talk about children needing palliative care. Because children don't die. Is it because children don't die? Only adult, old age, bedridden patients die, and we don't think about children dying of life-limiting illness. Do we think about children when I tell life-limiting, life-threatening, serious health-related suffering? The picture that we have is always an adult picture, right? But it is also about children in many, many conditions like neonatal conditions. Some children, most of the children born with anomalies will need care till they are alive. Many other endocrine abnormalities, kidney disease, hemophilia, sickle cell anemia, lot of illness which needs palliative care from the time of diagnosis. And how to whom all we can deliver palliative care? Is it you can create a tick box? Okay, you have cancer, you get palliative care. You don't have cancer, you don't get palliative care. Is it like that? Does it work like that? Now we mentioned a spectrum of illness, right? So it is not about what diagnosis the patient has. The diagnosis is never the criteria. You have to remember that no matter whatever points you take away from today's session, it is not about the diagnosis. Many a times when we refer patients, especially outside the state, when we tell them, okay, why don't you take palliative care services? Then they say, no, but you don't have cancer. Why do you need palliative care? You don't have cancer. Many times patients, when they get referred to palliative care, they say, I don't have cancer, then why are you referring me to palliative care? So diagnosis is not the criteria. It is about whether the patient is undergoing any serious health-related suffering, whether the illness is affecting someone's quality of life. So it is not just about adults, it is also about children who needs a lot of support, because these children, most of them live for long, right? And it is about their siblings who will be taking care of these kids at home. Mothers usually get abandoned by the family. Usually it will be the mother and the children, supported by the mother's parents or siblings. So it is about supporting children who has life-limiting illness. It is not, we are not talking about old people or adults who need palliative care. And many times people say that, oh, you are referred to palliative care, that means you're going to die. I mean, patients used to ask me, one lady was referred for palliative care, very early stages of breast cancer. The moment I called her inside, she started crying. She was so much scared. So I asked, why are you crying? What happened to you? Are you in severe pain? So I started asking, then she told, no, I know why I'm being referred to this. I know a neighbor who died few weeks after referring to the illness was end stage. So am I going to die? So, and many times your colleagues, your friends will ask when you do palliative care that you're taking care of patients who are about to die. So it is not just about dying patients. There is a lot of study, and this is one of the landmark study. They studied patients with end-stage lung cancer, and they found that when they referred patients to palliative care early, the patients lived longer. They had a 3 months of longer survival than patients who are not referred to palliative care. So where do we deliver it? So we talked about for whom we need palliative care, what is palliative care, and now the where of it. Where do you deliver palliative care? It can be delivered in various settings. For example, you can deliver it in an inpatient setting where patients are very sick, they cannot travel, they cannot come to the OP regularly, they need some injectables, or they need some medications which needs to be delivered continuously. They have to have a inpatient setting. And yes, I totally agree, Sister Hema. Every healthcare setup should have palliative care. Every doctor should have a palliative care approach. Every patient may not need palliative care, but it is good to have that approach, at least when we are practicing, when we are seeing patients with chronic illness. And ideally, every health setting. So it can be delivered through inpatient setting. It can be delivered through home-based setting. Many a times what happens when you have a prolonged illness. So we talked about paraplegia, we talked about stroke, or someone mentioned about ALS. What happens to these patients? Do they need to be in a hospital all the time? Do they need admission in an inpatient setting? Are we giving some medications on a regular basis, admitting them? No. Sometimes they may not even need to come to an outpatient clinic, right? Yes, physiotherapy is the key there in many neurological illness or in many, even for cancer illness also, to relieve or to delay the weight loss or the muscle, passive muscle movements are necessary. So many a times these kind of patients do not need to be in a hospital. They may not be able to come to an OP. A patient with ALS or a spinal cord injury will need at least all of their neighbors to come, put them in a chair, and then lift the chair to somewhere, take them in a vehicle and come to you, right? So that takes a lot of effort. They need not come to hospital. So many a times what happens whenever they have a UTI or something, the doctor will write antibiotics, and as a routine, they'll write review after 2 weeks. Have you seen that? And then they take the patient into the ambulance just to review. And then the doctor will say, okay, now we can stop the antibiotics. So the patients need not be carried to hospital all the time for maybe catheter change, maybe for regular physiotherapy, maybe for regular medications. They need care where they are and when they need it. Just give me a moment. We have been telling most often they cannot be taken to hospital. You can see these kind of homes in most of your setting, I guess. I think Stella is from another country. Do you think, I mean, you see these kind of settings and difficulties in your country where they have difficulty in reaching the healthcare setting? Or is it slightly better than this? Okay, anyway, I'll continue. So most often the terrain is very difficult. Even we find it difficult to climb these places and travel through. There is no access to vehicles, and we expect patients to come to us, maybe for a catheter change, maybe for a bedside dressing, maybe for giving physiotherapy. We think that, okay, come after 2 weeks. How are they going to come through this kind of terrain after 2 weeks? So it is very difficult. So it is very important to have a home-based care, a community-based approach, so that the care can be delivered at the place where the patient wants it. And it is not just for the patient. Now you can see in the picture how participatory it is, right? Someone is giving, checking, maybe checking the blood sugar, and how participatory it is. It is about teaching the family members. Family members also become a part of the team member. They ask their questions. We tell them how to take care of the patient at home. And it is not just about us going once a month, delivering and coming back. It is about a participatory decision making and care delivery. because family member is there every day to take care of the patient. We cannot be there every day going and taking blood sugar or BP or clean the patient, right? We can't do that on a daily basis. So we have to empower or make the family members also participate in whatever care that we are giving at home. And we often forget about kids. Mr. A had 3 kids at home. What happens when someone has an illness in the family? We talk to the grown-ups. The moment children start asking some question, we tell them, no, you can't talk. You should not ask these questions. So many a times, most often, we don't talk about parents' illness to children. And they'll be wondering what is happening. My mother is so stressed these days. My father is not going to work. Every day he is becoming weak. Sometimes he's screaming out of pain and my mother is crying in the kitchen. I don't know what is happening. And I cannot go to school with seeing all this. So it is very important to talk to the children in the family. And we have a program, we have a kids collective where we support education for children whose parents are unwell. Because many a times when there is a life-limiting illness in the family, the children become the caregiver. The children starts cooking and serving for the mother. The children starts cleaning the home. And then the mother has to go for work because the father is unwell. Someone has to be in the home to give water or the feeds to the father. So and many a times the finances not allow them to go to school. Okay, then they think, okay, let's stop their education. You can become the caregiver. Right? So their education can be discontinued. So we make sure that children can get the basic education when someone in their family is ailing. So that is a kids collective that we have. But it is not just about supporting their education. We always have to make sure that you talk to patients' children. What is that they are thinking? What is it that they are going through? And what questions they have about their parents' illness. So with that, I stopped my presentation and I'm happy to take a few questions.
Thank you, ma'am, for the wonderful presentation. I think we can wait for a few questions. Anybody have any questions or any clarification? So I think ma'am's class is clear to everyone. So we can move on to the patient story. Today, Sister Reshma will be presenting a patient story for you. This is a model presentation. Sister Reshma is a nurse who is working as a in charge of nursing for the home care department here. Reshma, it's over to you. So the next session onwards, one of you should present a patient story based on the session.
I think there is a question. Can we take it up?
Yes.
Please
Yes.
go ahead.
Hema?
Yes, ma'am. I have a question regarding this. You mentioned earlier that for the children, we have to start palliative care. And my question is for the family of the children who are suffering from the lifelong illnesses or congenital diseases, we might have start the palliative care services. But how we communicate to the children who can't understand, their psychological problems can't be met. They can't go to the school as the regular kids, and they can't play as to the regular kids. The kids might be having a chemo port or something else, or hydrocephaly, whatever. They can't be doing their normal regular activities comparatively to other kids. So how we can support them psychologically other than the medical things?
I think medical things have a lot of limitations there. I think psychological support plays a major role. So very importantly, it is acknowledging that there is a problem. They are not having. So as you said, for example, a person having or a kid having a chemo port or having some anomalies or they are mentally strong, but they know that they cannot be going to a normal school or play around, like you said. It is very important. The first thing is to acknowledge that there is a problem. What happens is that, no, everything will be all right. After your illness is cured, then you can also go. Or you will be all right soon, then you can also play. That's how we tend to prematurely close the conversation, because we are scared we may not have answers to those questions. So first thing is to acknowledge that, yes, I understand that there is a problem, and let them talk to you about it. Let them tell you what they are going through. Otherwise, what happens is that they will not talk to anyone, because the parents will tell that, oh, don't talk like that, everything will be fine. There is no one to listen. They have to tell you that, see, I am having, especially teenagers, I am having a lot of issues because I'm not like a normal child. Like, I have heard children on teenage, like, I would like to have a girlfriend, but I'm never going to have that. When I also want to have a normal life, which I want to ride a cycle, which I am unable to do. So it is important to listen, tell them to, I mean, let them open up to you. We may not be able to fix everything and make him ride a bicycle, but it is important to be a good listener and identify what other areas that can be focused. Like one person, so he was interested in some instruments. Okay, how can you initiate something that which can be done at home? Nowadays, everything, all the trainings are available online. So find a donor, buy a guitar, which if he is interested, let them do that, and support groups. Many a times we can help them to come into groups and start interacting with other children. So if they are not immunocompromised, talk to the school, whether they can be just there, although they are not actively coming every day. Can the child be there in the classroom, be with other students and mingle with them? Just talk to the school management. Many a times they may need some special care, probably. So it's important to have a conversation with the school. We are not going to fix the whole problem that they're going through, but acknowledging that a problem exists and give a place where they can talk about this without any fear. That's the first step.
Yes, ma'am. Thank you, ma'am. Like for this school going children, it is like fine. We may ask to the management of the school, and also the child who is like playing, we might set him or like her a very good environment. But for those kids who don't speak, like
Yeah.
if at all the child is like having like for the adults and the teenagers, they might speak if we listen good to them. But the children who don't speak, or like they are yet to speak, or like they have some speech disorders, like so many things. So if they don't communicate in such a way, like we can't understand. So like without understanding what, like of course we don't know what they are, we can like generalize with a stereotype. They might be going through these many things, but we can't specifically like I don't know how to specifically treat them without knowing what they're going through, or like without they communicate to us. So in such cases, what we are supposed to do to those kids?
Yeah, I think there is no, I mean, that's definitely a difficult area for anyone. We also have a pediatric palliative care services. When the child is unable to communicate, we can't really do much about it, but maybe it is important to try to engage this child with whatever you can. Have conversations, and that I'm sure you might be already doing. Have conversations.
Yes.
Sometimes they may get attracted to something when they, sometimes they will be fascinated when you start drawing or writing something. They show their interest in doing something. So if you can identify something like that, encourage that, and having a conversation. If they, even if they cannot speak back to you, just keep talking to them, will be one thing.
Okay.
I'm sure it is not an answer. You might be already doing it, but that's one area which doesn't have any ready-made answers. And it is very important at the same time to talk to the sibling, because the family's focus will completely come to this child who is unwell, which happens invariably in all families. So all the energy, planning, the money, the time, the affection completely gets to the child with having the illness. So it is very important to spend equal time with their siblings. Make sure that the sibling is also coming once in a while to the clinic. They might be going through a tremendous trauma, because my father or mother doesn't have time to talk to me because the energy is diverted to the other child.
Yes, ma'am.
They get one chocolate, that will be given to the sick child, not to the sibling. So that
Yes, ma'am.
they get a toy, And when we give them toys in the clinic, we give to them, not to the siblings, right? So that
Yeah.
when they take this back home, then the sibling will be, oh my God, if I had the illness, I would have gotten the toy. So it is very important to
Take care
not
for the child too.
tell them to bring the sibling once in a while. And child who is not communicating, we can communicate to them. They might show some interest in something, they get connected to something, then maybe we should explore more on that. It takes ages to get those connections. It is not at all easy. It is the most challenging part.
Okay, ma'am. Thank you.
Good evening all. Today I am presenting a patient story of 39-year-old male diagnosed with traumatic quadriparesis with stage 4 pressure sore on sacral region and the gluteal region. Presenting complaints at the time of admission, patient complaints of constipation since 2 days, bed sore over sacral region and gluteal region, complaints of moderate pain over the hip region and urinary leakage. And the history of presenting illness, he had history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic quadriparesis in August 15. Admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and the gluteal region. It was stage 5 and the history of pain over the hip and wound site for more than 2 weeks. Pain over the hip region bilateral. Pain score was 5/10, intermittent in nature and burning type of pain. And the wound site, the pain score was 4/10, continuous throbbing type of pain. And due to this, sometimes they keep the wound open. Sleep was disturbed and oral intake decreased. On examination, patient was conscious and oriented and all the other parameters are within normal limit. Next. And about the pressure sores, their warmth and tenderness present and exudates present, tunneling present and irregular in shape and foul smelling. Treatment and significant investigations, all routine investigations done after the admission and all the parameters are within normal limit. About the psychosocial aspect, 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now his mother is a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wages, her pension and some of his friends. Have taken rupees 1.5 lakh from private finance bank for the treatment purpose. They are devout Christian, now unable to go to church and this makes him very sad. He communicates through the cell phone and he says to his mother like, I don't think I can walk, so please don't spend money over my treatment. The main concerns are pressure sore, pain and the financial problem. Summary. 39-year-old man with traumatic quadriparesis with bed sore present over sacral and gluteal region stage 4 with pain over the hip region. The discussion points are, do we need to provide palliative care for this patient? What are the problems faced by this patient? And what all can be done for this patient and his mother?
Thank you, Reshma, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I think this presentation is clear to everyone. We can move on to the discussion points. We would like to hear from you all. So now we heard about palliative care. Now this is the patient story. So please tell us, do we need to provide palliative care for these patients? If you say yes, please describe why you say yes. Okay, this patient needs palliative care. Why? Why you think like that? Hema said he has self-limiting illness. Okay.
Since he is the breadwinner in the family and is not able to go to work back to his normal life, so he does require.
Okay. Thank you. So, anybody in this group say no? So we all agree now. This patient definitely need palliative care. This patient is having a life-limiting illness. Definitely, this patient needs palliative care. So, madam, anything you want to add?
There are many chats coming up. Why he needs palliative care? Because he is bedbound, reduce further complication, and symptomatic management of bed sore and constipation. There is a point on vocational rehab can be given for future. So everyone agrees that he needs palliative care. I don't know how many places he will get palliative care in this group. I mean, most of the places paraplegics are not considered who can get palliative care. But yeah, I'm glad that you understand that there is a need and it is needed. That's all.
Okay, thank you, ma'am. So, and also you have to think about the primary caregiver. So, who is the primary caregiver of this patient? Mother. Do we need to provide palliative care to his mother? So,
Yes, because they have taken some loan from the private bank, and the mother is now going to work, and she's become the earning member of the family. And the son is fed up. He's saying that he won't come back to normal life. So stop spending on him.
okay. Any other points?
As she's the only person to take care of the patient, so she will be like having her own limitation. She can't be doing her regular activities properly, and also she can't go to like work properly. She will be like hospitalized along with the patient whenever it is needed, or else she have to be next to the patient whenever the patient calls. So she will, of course, she will go through a lot of psychological issues. So that to be addressed and that to be like treated often, and she should be like the one we have to consider much more because she have to take care of herself too, and and also she have to know much about the patient care. She might not be knowing how to take care of the bed sore, like how to prevent the bed sores also, and other disease related things which she should be taking care of. So that should be assess in the patient's attenders, the caregiver, especially the mother who is in this scenario. So she should be addressing this palliative care service.
Okay, thank you, Hema. So, on important points we should keep it in mind is if a person get an illness in a family, the whole family will be affecting. So throughout the patient, the treatment, the caregiver also affected. But when the patient come to us, we all focusing on the patient. Nobody is bothered about the patient family or caretakers. So we have to give a special attention to the caregivers too. So we need to listen their emotions, because the relatives come to them and blame them. So, and the neighbors also blaming them. So nobody is there to listen their problems. So we are the person to listen their problems. Okay, they are the only one persons to take care of these patients. Without caregiver support, we can't do anything. So we need to empower the caregivers and we need to support the caregivers. So this definitely this in palliative care, we have to give a care to the patient and to the family. Okay. And the next point I would like to highlight here is we all should keep it in mind when the patient come to us. When the patients will, so if the normal person will not come to us, if a person get an illness, they will try all the home remedies first. If that home remedies failed, they will come to us. When they come to us, we have to think why they are come to us. They will expect something from us, care or anything. So they will expect, sometimes they will having a curative problems, curable illness. Even then they will expect something from us. Okay, so always you have to keep it in mind. Whenever they come to us, we are the person to give care. So you have to be a good listener. You have to approach the patient as a pleasant face, and you have to be a good listener as well as you have to take care of the patient as a whole. So this patient need a total care. All patients need total care: physical, emotional, social, and spiritual care. If you are able to provide total care to the patient, definitely we can able to improve the quality of life of the patient and their family. Okay, so next we can move on to the next the discussion points. What are the problems faced by this patient? So, please share your thoughts. So what are the problems? Do you think this patient need only physical care? So we need to address the patient problem. Okay, so we need to identify the physical problem, social problems, psychological problems, and spiritual problem. After that only we can able to provide total care. So we have to do the proper assessment. So just discuss what are the physical problems, what are the psychosocial problem, and what are the spiritual problem for this patient. Okay. So Reshma, go back to the previous slides. Okay. So this is the psychosocial aspects of this patient. Please unmute yourself and talk, or you can put your answers in the chat box. Vinisha, Sindhumol, and all says physical, psychological, financial. Definitely, this patient need these all support. So before that, we have to identify whether this patient is need this help, because we have to do the proper assessment. So from this patient story, what are the problems you have identified? What are the physical problems? What are the psychological problems? What are the social problem? And what are the spiritual problem? we have to list down. Tell me, only 5 minutes more. So, okay, physical problem. Sister Binisha said bed sore, pain, poor mobility. Okay. Then, what are the psychological problems, psychosocial issues?
He's not able to walk or do his like self activities, like activity of daily living. He can't do, and his body image is like deficiting because he won't be having that confidence what he was having before, and also he's smelling bad, so terribly. He won't be like having social intelligence, and if at all people are coming to meet him, also he won't be meeting him just because of his own self-confidence lacking will be there, of course. He's like bedbound. He will be having like so much of problems other than this, like urinating will be an issue for him. Defecation will be an issue for him. And of course, eating will be an issue for him. He can't like keep on disturbing the caretaker. So like after a certain period of time, he will be having this guilt to make his mother in such a position. And of course, he will may end up in suicidal tendency, long-term deprivation, depression, and all.
Yes. Thank you, Hema. So as Hema said, a lot of problems, physical problems, psychosocial problems, like even spiritual problem is also there. So if you do the proper assessment, definitely we will get good idea, get a good idea about the patients. So based on your assessment, you will try to help. So if you are not doing proper assessment, we don't get the proper problems about the patients. So you have to do the proper assessment first. So I think we did many things for this patient. Reshma. Next. Yeah. So to you.
The first discussion point is, do we need to provide palliative care for this patient? Definitely yes. As he is in a life-threatening situation, he has serious health-related suffering. His quality of life is definitely affected due to illness. Palliative care is not only for cancer, end-of-life situations, it applies to any health-related suffering, and the above patient story is an example for this. And the second discussion point was, what are the problems faced by this patient? He has physical issues such as pain, bed sore, urinary leakage, insomnia, loss of appetite, etc. He has spiritual issues as mentioned in the presentation. And feeling of being burdened to the caregiver, financial issues are there, and identify the issues, foul smelling, wound over his body, then social isolation, loss of independence, loss of job, anxiety, depression to be ruled out. And the third point, discussion point was, what all can be done for this patient and his mother? Community mobilization for regular visits, fund generation if possible, and vocational rehabilitation for the patient and his mother, and empowering the mother to take care of daily care of him, like position change, bed sore, dressing, etc. Any respite for the caregiver for few days. Look at the health issues and emotional issues of the caregiver also, and make him feel that he is useful and convey that we care. Thank you.
So from this patient story, I think it is clear, because when we get a patient, definitely we need to do the proper assessment in 4 aspects. So instead of physical aspects, we have to look into the psychosocial and spiritual aspects too. If you look into the 4 aspects, definitely we can able to provide total care. And from this this patient story also we did many things for this patient. We had that made a call to his friends, and his main that the spiritual concern was not able to go to the church. So because of his that condition, he can't. So what we did was we called his friends and make arrangements, and usually every Sundays they came to his home and take his home, take this patient to his church. So that kind of things you can do. So if you develop a community like this, definitely the community will do these kind of activities, because nowadays the lack of awareness, nobody's know what is palliative care. So we have to give a proper awareness to the community. Then, so definitely 1 or 2 persons will be there. Then they will support these kind of people into the community. So, ma'am, do you want to add anything?
So Shiva, no, nothing more to add.
Okay. So I think we can now wind up the session. Now it's 4:30. Can we wind up? Any other questions or comments? Anything? So we can wind up the session. Ma'am, thank you so much for the wonderful session. It was a nice experience for us. So they all understand well about palliative care. Thank you, Reshma, for presenting a patient story. So I would request you to all to send a patient story. So as per senior's request, that is very, very important. Based on the session, we have to discuss like this. So please submit your case presentation as soon as possible. Thank you.
Thank you all for joining for today's session. I have shared the feedback link. You are supposed to fill it up and complete the feedback after every session. So kindly go through it and fill it up. Thank you all for joining. We'll see you on the next session. That's on Thursday. Bye.